The title of my talk is Pulmonary Hypertension, ILD, Does Treatment Improve Outcome? And the answer to that is, I don't know. So there, I saved a lot of time. But these are my disclosures. And as you're aware, we have multiple medications approved for group 1 pulmonary arterial hypertension. One of them is approved for group 4, that's riociguat, for CTEPH. There are no medications approved for group 3 pulmonary hypertension, so anything I mention in terms of medications is off-label. And this is the current classification. It was tweaked a little bit at the World Symposium that was held in Nice in 2018, but interstitial lung disease remains under group 3 pulmonary hypertension. The one big change, or little change, or tweak was that LAM got shifted from group 5 to group 3. If you look at the distribution of mean pulmonary artery pressures in IPF, and this is a paper we had a number of years ago in CHEST, you can see that pulmonary hypertension certainly does occur, but most of it tends to be mild. It tends to be centered around 25 to 30, maybe 30 to 35. So severe pulmonary hypertension, as we define it, greater than 35, is somewhat rare in IPF and other ILDs, except CTD-ILD, I would say. Now, at the 6th World Symposium, there was another change. They changed the definition on us, and actually, if you read the two task force statements, the definitions are a little bit different for pulmonary hypertension and then group 3 pulmonary hypertension. But the bottom line of this, without getting into any great detail, whereas previously we defined pH by mean PA pressure 25 or more, now it's inclusive of patients 20 to 24, provided the PVR is greater than 3. This PVR greater than 3 also applies to patients who have PA pressures north of 25. So I'll show you something we did recently. This is based on the UNOS database, and we have this paper in submission at the moment, so if there are any potential reviewers in the audience, please be kind to it. I think we've been rejected by 2 journals so far, and give me your name if you're going to think favorably of what we've done. So what we did, actually the biggest database in the world of right heart caths is UNOS, and there are over 19,000 patients with lung disease who have had right heart caths in UNOS. So what we wanted to see was who changes, who qualifies as having pulmonary hypertension and who gets disqualified. And so here we see that 15.3% of patients who previously did not have pulmonary hypertension now have pulmonary hypertension, and also 18.7% of patients who did have pulmonary hypertension no longer qualify as having pulmonary hypertension. So that means their mean PA pressures were greater than 25, but their PVRs were less than 3. If you look, by virtue of the old definition, at the prevalence of PH in IPF, it's kind of all over the place. It depends when you look at it. It's as little as 8% to as high as 86%. If you look at patients with more advanced disease, it's going to be significantly more than if you look at patients with earlier disease. An interesting study is the one second from the top. Ganesh was the first author on that, and this was from the Artemis IPF study, which was patients with mild to moderate disease, and there the prevalence was surprisingly high for mild to moderate. It was around 15%, with another 5% having group 2 pulmonary hypertension. What happens when you put 2 bad diseases together, ILD plus PH? It's like taking this and mixing it with a little bit of that. So the prognosis is not very good, and this is shown over here. This is from the same paper that I showed you the histogram distribution. So even patients who have mild pulmonary hypertension have distinctly worse outcomes in the context of IPF. And if you compare PH-ILD, idiopathic interstitial pneumonias, versus IPAH, the prognosis is distinctly worse. This is from a European registry, the Comparer registry. This is a paper that we had published many years ago as well, where we looked at right heart cath data at the time of transplant evaluation, and then managed to get their right heart cath data when they were in the OR about to have a transplant, but before any incisions had been made. And the prevalence at the time of the eval was around 30-35%. By the time they were in the OR, it was around 85-86%. So it seems like as these patients progress, it's almost invariable that most of them will develop pulmonary hypertension. What we also know is that these patients walk less and desaturate more. So the 6-minute walk is an important clue to the presence of underlying pH. Those patients who can't walk very far, get tachypnic, need a lot of oxygen, likelihood is quite high that they have pH. And there's also at least one paper looking at the association between pulmonary hypertension and acute exacerbations. And so it's the same for many different lung diseases where this a similar association has been demonstrated. Excuse me. This is an interesting analysis that we did where we looked at deciles of lung function and looked at the prevalence and severity of pulmonary hypertension. Prevalence here, severity here. And if it was all due to restriction and progressive fibrosis, you would expect the prevalence to go up as the decile in lung function goes down and the severity to go up. But what you can actually see is that the pressures were pretty similar within these deciles, and the prevalence was actually very similar. And actually, paradoxically, if you look at those folks with FVCs greater than 70%, prevalence 62%, FVC less than 40%, prevalence 36%. So kind of the opposite of what one might expect. I think that's some of the beauty of doing research. Sometimes you find things that are exactly the opposite of what you expect. Now, I don't have a good explanation for this, except for perhaps these patients come to clinical attention earlier because they've developed pulmonary hypertension and are more symptomatic. And perhaps this represents a survival bias in that patients who have significant pulmonary hypertension will likely succumb before the FVC gets to less than 40%. These are some clues to the presence of underlying pulmonary hypertension: disproportionate pH, a loud P2 heart sound, a low DL. Sometimes we look at the FVC to DL ratio. I mentioned the role of the 6-minute walk. There is other information within the 6-minute walk, like a low pulse rate recovery. That might be an indicator of underlying pulmonary hypertension. We look at the PA segment in relation to the aorta, and that's an important clue. And then there's some biomarkers, BNP and NT-proBNP, and even RDW, the red cell width distribution, has been linked to underlying pulmonary hypertension. And of course, echo is our main screening tool, although we never make the diagnosis of pulmonary hypertension based on echo alone. This is an example of a CT in a patient with IPF. Can measure the PA, which is large comparison to the aorta. And we actually looked at a bunch of patients from our clinic in terms of the PA size, PA to aorta ratio, and did demonstrate that this was an independent prognostic indicator. Shown over here, these patients do distinctly worse, even when you control for other variables. Echo, we know, is a very good screening tool, but it can both overestimate and underestimate what the pressures are. So in the context of group 3, right heart cath remains the gold standard, as it does for all forms of pulmonary hypertension. So what we know that pulmonary hypertension commonly complicates the course of the ILDs. It's associated with worse survival, reduced functional status, and possibly acute exacerbations. What we don't know is if pH is the driver of outcomes or if it's a surrogate for something else going on in the lungs. And then we talk about, but we don't really know what disproportionate pulmonary hypertension is. That term's gone out of favor. What we don't know, but shouldn't be too scared to ask, is whether or not we should treat pH. If we do, does it affect functional status? What about survival? And do we run the risk of doing more harm than good if it's somehow an adaptive phenomenon? So these are all the drugs that are approved for group 1 pulmonary arterial hypertension by year. So you can see that there are many. The more drugs there are to play with, the more enticing, the more tempting it is to try these drugs beyond group 1 and in group 3. So we've all dabbled with this, but whether it works or not, we'll try and address. So conceptually, can we take a disease, take a prognostic indicator, a biomarker for worse outcomes, and do this? Have this patient, and take Mr. Orange Dot and put him on the green line and improve his survival. It's almost too good to be true. They have pulmonary hypertension, you treat it, they should do better, right? You just have a tough time showing that. This is another concept slide looking at what happens with interstitial lung disease, what happens to the vasculature, and conceptually, is there this inflection point where the pulmonary vasculature and pulmonary hypertension drives outcomes rather than the parenchymal lung disease? And this is supported by, if you look at all the different lung diseases, we know NSRP has a better prognosis than IPF, chronic HP has a better prognosis than IPF, But once they develop pulmonary hypertension, they all look exactly the same. They follow the same common path to mortality once they develop pulmonary hypertension, perhaps indicating that pulmonary hypertension has now superseded the parenchymal lung disease and is driving their outcomes. Another concept slide, can we improve their symptoms? Patients have parenchymal disease, ILD, they have pulmonary hypertension, and they have a breathing limitation. What's causing the breathing limitation? If it's a pulmonary hypertension, can we do this? Can we put them on treatment and affect that to the point that their parenchymal lung disease now becomes their limitation? This is a diagram that we included in the World Symposium Task Force statement that was published in the ERJ in January of this year. I was privileged to be the co-chair of the Group 3 Task Force, and there's a lot of stuff and fluff here that we've spoken about already. We kind of hedged our bets, couldn't say too much in the context of this task force. But the reason I show the slide here is as we try and decide who to treat and if to treat, we've got to look at what their impairment is in relation to their hemodynamics. We've got to look at not only their physiologic impairment, but their morphologic impairment. And I think that's something that's previously been underappreciated. We've typically looked at their FVC or FEV1 in the case of COPD, but we really got to look at the pattern of injury and the extent of parenchymal injury based on imaging. And I think that's an area that we've kind of glossed over previously, but certainly something to look at moving forward. So there are caveats that we have to think about in terms of treating ILD PH. Firstly, the concept of worsening VQ. I think this is more a concept that hasn't really been borne out in reality. There is the notion of perhaps PVOD, pulmonary veno-occlusive disease. We know from the world of PAH that that's the one contraindication to PAH therapy. We don't treat patients with PVOD because it's kind of like backing up the dam. You unload the RV and there's resistance on the venous side and you can put them in pulmonary edema. What we do know in certain diseases like IPF and even scleroderma is that you can have PVOD-like lesions. So this might be why some patients don't do well. And as we talk about future clinical trials, how do we pass out these patients who might not do well with treatment? The same concept for occult heart failure. If you have a stiff LV, a stiff left atrium, and these are elderly patients, giving them a vasodilator potentially can put them in worse shape and put them in pulmonary edema. And then extensive parenchymal disease burden, and this is something that I added after the experience of the RISE IRP study, which we'll talk about towards the end. Most folks will recognize this as a low power of a patient with a UIP pattern. You see extensive fibrosis, areas of normal lung, and a sharp line of demarcation between abnormal and normal. And if you look in the areas of fibrosis, you're going to generally see obliterated vessels. And no one thinks or believes that we're going to affect these vessels by putting patients on PH treatments. But if you look in areas that are within normal parts of the lung, away from the fibrosis, you do have vasculopathic changes. And this is very much akin to CTEPH, chronic thromboembolic pulmonary hypertension, where you have mechanical obstruction of some vessels, but we treat with riociguat specifically for the small vessel vasculopathy that occurs in areas adjacent or distant to the areas of mechanical obstruction. And a similar analogy holds true in IPF and other ILDs. So I'm not going to talk about all the different studies. I'll show you 2 or 3 slides summarizing the prior studies that have been done in ILD and IPF. Most of them have been relatively small, open label, a few RCTs. I've color-coded them for ease. Green is good, red or pink is not so good, and orange is neutral in terms of the results. So there's that, a lot of pink in there. And I will focus on one study or a couple of studies. The first one is the STEP IPF study. This was through the NIH IPF network, where they looked at sildenafil with the patient population enriched for pulmonary hypertension by having the inclusion criteria of a DL less than 35% are predicted. And if you look at the STEP study, which was sildenafil 20 TRD, done over the period of 12 weeks with a further 12 weeks of follow-up, it was a negative study based on the chosen endpoint of a 20% increase in the 6-minute walk distance. However, if you read the actual article, there are a bunch of secondary endpoints that suggested benefit in terms of quality of life, dyspnea, the St. George's, the oxygen, and the DLCO. And there was no mention in the paper, but there was also a suggestion, perhaps, maybe, of a mortality difference, 4 in the sildenafil group versus 11 in the placebo arm. But once again, the numbers were very small, and this was not discussed appropriately in the context of the trial, but that's out there. There was a subgroup analysis from the STEP study that was published in Chest a couple of years later in 2013, and what they looked at were patients, a subgroup of patients from the STEP IPF study who had evidence of right ventricular systolic dysfunction. And what they showed in that subgroup was that these patients actually did quite well. They had a 100-meter increase in their 6-minute walk distance. We know that the RV drives outcomes in PAH. We know it drives outcomes in heart failure, in CTEPH, and maybe it's RV dysfunction, once that sets in, that drives outcomes in patients with ILD. This was a study out of UCLA looking at treprostinil in patients with severe pulmonary hypertension, mean PA pressure greater than 35, and they showed, I'm not going to get into this in detail, but there was a positive outcome in terms of echo findings, 6-minute walk, everything looked to be positive. These are the echo findings that were positive, and there were a good number of patients who improved their 6-minute walk distance significantly. So once again, small series, 15 patients, but suggestive perhaps that there is a phenotype of patients who are responsive to treatment. This is from the Compara registry, once again, looking at patients with IIP PH and looking at the treatments that they were on. Most of them were treated with PD5s, and looking at the outcomes, and what was very interesting to me from the study was the outcomes in terms of the 6-minute walk distance was very similar to IPAH. If we look, for example, at number of patients improving by more than 50 meters, 36% versus 31%. So I was quite surprised by this result, but once again, this was a retrospective registry report, so caveats to that. Let's skip through that. Let's move on to riociguat, which has been extensively studied at this point. This was a phase 2 study that was published in the ERJ 6 years ago now, suggesting benefit from riociguat in patients with ILD. Just to point out some of the highlights from this, walk distance was improved, hemodynamics were improved, and this seemed to be a very solid basis for doing a bigger study. And this led to this study over here, the RISE-IRP study, riociguat for idiopathic interstitial pneumonia-associated pulmonary hypertension, a phase 2b study. I was privileged to be the PI on the study, was very intimately involved with the study, and it generated a lot of excitement. At the time, it was published, I think in September, in Lancet Respiratory Medicine. These were the inclusion criteria. We tried to keep it pretty broad, FVC greater than 45%, had to have pulmonary hypertension, and then some typical exclusionary criteria. We did allow CPFE patients in, provided the extent of the fibrosis was greater than the extent of the emphysema. These were the patients that were enrolled. It looked like we were getting the right patients in. As expected, most of them had IPF. About 2/3 to 3/4 had IPF. My big concern going into the study was that we get patients with mean PA pressures of 26 and FVCs of 46, but we did quite well in terms of recruitment. Mean PA pressure 33, FVC around 76, 74%. So as we were recruiting, we felt like we were getting the right type of patients and a good group of patients to show benefit. Then one day, I can't even remember how many years ago it was, 3 years ago, 4 years ago, get this urgent call or this urgent email from the Data Safety Monitoring Committee that they wanted me as the PI together with the sponsor on the phone. They needed to talk to us right away. So within the hour, we were all on the phone, and they said, we're looking at the data, and you need to stop the study for increased harm in the treatment arm. So the RISE-IRP study was halted, and all the patients were taken off drug within 24 hours. So let's look at those results. Disappointing to say the least. In the main phase of the study, the main thing that appropriately got the attention of the Data Safety Monitoring Board is this over here. Deaths in the RIO arm, 11%, 8 deaths, and 3 deaths or 4% in the placebo arm. But what was of more concern was as patients were finishing the main part of the study, they were rolling over to open label therapy, including placebo patients who are now going to be put on riociguat. And this is what happened. Former placebo, there were 8 deaths in the former placebo arm. So the DSMB was rightfully concerned that patients were coming through and going to be placed on Rio and potentially be at risk of mortality. And that's the reason the study was stopped early. So a couple of quotes to kind of comfort me when I started crying about this. The great tragedy of science, the slaying of a beautiful hypothesis by an ugly fact. If you can find some solace in that. Another one. We hate the very idea that our own ideas may be mistaken, so we cling dogmatically to our conjectures. And so you have to believe the studies. That's why we do the studies, even if it doesn't go the way that you're hoping and believing. And the last one kind of summarizes where I'm at right now. Some problems are so complex that you have to be highly intelligent and well-informed just to be undecided about them. I don't pretend to be highly intelligent, but I still hold out hope that there is a phenotype, that there is a drug that will show benefit, and we'll talk more about that. So why did RISE fall? And there are 4 C's there: composition, compound, conduct, concept. Did we get the patients wrong? Did we enroll the wrong patients? Did we have the drug wrong, the wrong compound? Is there something inherent to Rio? Was there something in the trial conduct that we didn't know about or shouldn't have happened? I don't think so. And is the whole concept wrong? Should we not be treating pH complicating ILD? As I mentioned, we don't know if it's an adaptive or maladaptive phenomenon, and maybe it's adaptive, or maybe we've been enrolling too many patients where it is an adaptive phenomenon, and that elusive maladaptive or disproportionate group remains to be defined. So with that said, there are lung disease patients with hemodynamics that look like they have PAH, and it becomes a semantic and philosophical discussion in terms of what you call them. You say, well, this patient's got some ILD, but clearly they have PAH as well. The mean PA pressure is 50. This can't be due to the ILD, and then you can potentially put them in group 1. The option to treat such cases can be difficult to ignore in the clinical trenches, even with a lack of supportive RCT evidence. And I think we've all seen this. I find it very difficult to ignore a patient who has a mean PA pressure of 50 and a cardiac index of 1.7. Generally, I will treat a patient like that in the context of lung disease. I won't treat a patient whose mean PA pressure is 27 with a cardiac output that's normal. So I think that there are these patients who benefit. And this is where clinical judgment and the art of medicine, sorry for the word, trump the paradigm of practicing within the constraints of evidence-based medicine. You can always come up with some fake data to support what you want to do. So I also get solace from this, and this is plagiarized from Luca Ricaldi. I feel like there's an Italian orchestra in the background playing as this builds. This is Luca's slide. Of all the studies we've done in IPF, and we had so many negative studies before we had the positive studies. So my feeling is we need to persist. If we hadn't persisted with IPF, if we hadn't gotten disheartened and said, well, nothing works in IPF, then we're going to give up, we wouldn't have the drugs we have today. We wouldn't have the clinical trials that we have today. So I don't think we're at a point yet where we're going to give up on the concept of treating group 3 pulmonary hypertension. But this does raise the notion of how do you do a study? How do you prime it for success? And there are many parts, many moving parts to get a study right. And here we have a graphic display of them. A drug, first of all, you need a drug that works and is well tolerated. And if we get the pill through that little hole and manage that, then the next step is you've got to get the right dose, the right frequency, and the correct route of administration. Maybe we've got it all wrong. Maybe it needs to be inhaled. If you get it through that step, we'll squeeze the pill through. There, we did it. Okay. Then you've got to define the right patient population, the right phenotype that is recruitable and retainable. We can all design a study where we say, well, they need a mean PA pressure of greater than 50 and it has to be IPF. We're never going to recruit a study like that. If you get the pill through there, final step, then you have to define the right duration, 12-week study, 26-week study, and the right endpoints. In the context of pH, is it 6-minute walk? Is it time to clinical worsening? What should it be? The final step, you get it through there, and then we have a pill with a pulse. So you can see how many places a trial can get tripped up. These are some of the ongoing clinical trials that we have at the moment. going to focus on just a few. Inhaled nitric oxide. There's actually 2 abstract presentations at this meeting on the use of inhaled nitric oxide. I'm not going to get into much detail about this, but this is a very attractive option, ambulatory nitric oxide for patients who are on oxygen already. We presented the data at ATS and then had another presentation at CHEST. What we used for the endpoint is actigraphy. Patients go home with an actigraph. I always have a problem with that word. Activity monitor, a Fitbit, but not actually a Fitbit, a different device that has been very well validated. And what we've shown is that moderate to vigorous activity increases in these patients if they go home with inhaled nitric oxide. That was the first phase of this clinical trial program. We fully recruited the phase 2 of this clinical trial program, and we hope to have results in the coming months to that. Excuse me. Inhaled treprostinil, that's been studied at the moment. This is the INCREASE study, which has been or will be the biggest study to date in group 3 pulmonary hypertension. Over 300 patients, the study is closed. We hope to have some results on this early next year. So this is very exciting, and we'll see what that shows, and hopefully we'll have a presentation around this at ATS. And then sildenafil together with pirfenidone. There was a study of sildenafil and nintedanib that suggested benefit. Now sildenafil plus pirfenidone. This is also 176 patients. Disease progression is the endpoint. So can we layer on pH therapy on top of antifibrotic therapy, which I think, or I hope, will be the next step that we go. So should we treat group 3 pulmonary hypertension? And this is my final slide. Depends which way you look at it. You can look at it this way, forget it, go for it, but at the end we need to study it. So I'll stop right there. Thank you very much.